Well, it is my pleasure to introduce our 2 p.m. panel. Dr. Charles Bulasingala is a cardiologist and associate professor at Baylor College of Medicine, and he currently serves as the director of the echocardiography lab and is vice chief of operations in the Department of Medicine for Bentop General Hospital. I'm also going to introduce our second and third panelists. Dr. LaShawncy Woodard is my postdoc mentor, so I'm very excited to be moderating this panel. She is a professor in the Department of Internal Medicine and Associate Dean for Community Engagement at Baylor College of Medicine. And Dr. Omid Veza is professor and Separate Scholar in Cancer Research in the Department of Bioengineering and Chemical and Biomedical Engineering at Rice. And he is also the director of Rice University's Biotech Launchpad. And I did not introduce myself. My name is Dr. Isabel Custers, and I'm a faculty in kinesiology, public health sciences here at Rice University.
I'm happy to be here with you all. Thank you so much for having me. And I just have to give a quick shout out. I know that there are several students here from the DeBakey High School for Health Professions, which is a collaboration between Baylor College of Medicine and the Houston Independent School District, but also happens to be where I graduated from high school. And when I told them what year I graduated from high school, they said, whoa. So anyway, welcome. We're so excited to have you all here. All right, so I'm going to do a quick rapid fire progression through healthcare innovation and diabetes, thinking a little bit about technology, precision medicine, and patient and community-centered care. The latter is particularly important to me. It's what my research is focused on and what my current role as Associate Dean for Community Engagement at Baylor really centers on. All right, so first I just want to tell you I'm an internal medicine physician. I provide care to patients living with diabetes. However, the views expressed today are all mine and do not represent any official position and are not endorsed by any affiliation that I may have. This is a quick roadmap of what we're going to talk about today. And when I thought about this topic, healthcare innovation and diabetes, I really thought about it from my perspective as a primary care physician. So thinking about the rapid changes that we're seeing across technology, precision medicine, therapeutic advances, our healthcare delivery system, and then thinking about future directions as I think about what has improved care for the patients that I take care of and also their quality of life. So I think you all are likely very familiar with the prevalence of diabetes and the tremendous burden that diabetes poses worldwide. There are more than 800 million people living globally with diabetes, of which almost 40 million of those individuals live here in the United States. And importantly, we see the highest prevalence of diabetes in low and middle income countries. And in Texas, we exceed the national proportion of individuals with diabetes at 12.3%. So I think it's a huge public health crisis and important for us to think about the escalating healthcare costs that we see related to diabetes, within the U.S. alone being more than $400 billion, and in Texas, more than $25 billion. But also, as we think about those numbers, it's important for us to think about the promise that exists now. We are seeing tremendous emerging technology as we think about diabetes in the way we monitor, diagnose, and treat diabetes. And so that offers a lot of promise as we think about the future. In addition, we've done a lot of work to think about how we can make care more personalized. And we'll talk a little bit about that as we move through our presentation. But importantly, we are starting to think about things like genetics, environment, and how those things influence how we are more likely to develop diabetes, but also benefit from certain treatments that exist. And while we talk about all of this innovation, I would be remiss if I didn't highlight that the most important thing that we can think about with diabetes is prevention. Diabetes is more prevalent in individuals who are more sedentary, who have higher rates of obesity. And so it's important for us to continue to think about prevention as we think about diabetes and think about public health interventions and innovations in that space as well. So we're going to talk a little bit about technology. Now, it would be too much for me to cover the whole landscape of technology. So as I go through each of these categories, I'm thinking and highlighting one thing that gives you an idea of what these advances look like. So I start with continuous glucose monitoring. So many of you may have family members who have diabetes, and you know how they may check their blood sugars by pricking their fingers and seeing what their blood sugars are. Some people are doing that up to 3 or 4 times a day even. So if you think about that, that is a tremendous impact on their quality of life. Well, now we have continuous glucose monitoring, and continuous glucose monitoring allows us to have a small disc that a patient puts usually on their arm or their abdomen, and it continuously monitors their blood sugar throughout the day, and sometimes can even be connected to insulin pumps. And when that happens, as you see the fluctuations in blood sugar, the insulin pumps are also able to regulate the amount of insulin that they're delivering. And so what we see is that we see better diabetes control. We see that individuals are spending more time with their blood sugars in healthy ranges. They're having few of those episodes of low or high blood sugars. And with that comes a lower risk of being hospitalized, of having cardiovascular events, and of dying. And so importantly, this is contributing not only to better outcomes, but if you think about having to prick your finger 4 times a day, you can think about what a great improvement this is in quality of life. But as I talk about all of these advances, I'm going to continue throughout the presentation to highlight the lack of equity that exists when we think about access to this. And so this is a recent study that was in Diabetes Care that highlights that individuals who are older are less likely to have access to continuous glucose monitoring. So overall uptake after 2017 in older individuals is less than 10%. And the groups that are less likely to receive continuous glucose monitoring are older individuals, individuals with lower socioeconomic status, and racial and ethnic minorities. People who are more likely to receive continuous glucose monitoring are individuals who have lower levels of frailty, for example, and who are already using insulin pumps. So if you think about that, those are individuals who are engaged with our healthcare system, who likely have more connection and contact with our healthcare system. And so the individuals who may be most likely to benefit from those therapies don't have access to them. As we think about our monitoring and how we're able to actually take care of our patients who have diabetes, we also have to think about the other things that impact diabetes, not only diagnosis and development, but also treatment and outcomes. And so we've seen a huge shift towards precision medicine. And as we think about precision medicine, I won't go through all of these, but we're really thinking about the interplay of your genes, right? That's something we don't have a lot of control over, our genes, right? But also our environmental factors. So when we think about diet and physical activity, when we think about individuals who live in spaces where they're exposed to toxins, when we think about individuals who live in spaces where they're not able to get out and walk because it may not be safe for them to do so, or they may not have access to spaces to engage in physical activity, those are all things that contribute to higher rates of diabetes. So as we think about those things, we want to incorporate all of those things into the way we're developing more personalized care, thinking about that interplay of genetics and environmental factors and how non-medical drivers of health all come together to not only influence the development of diabetes, but also how we're able to treat diabetes. And importantly, as we think about precision medicine, I think it's important for us to remember, you know, there's been a lot of historic mistrust of the healthcare system. So when we think about clinical trials, for example, we've seen that there are communities that are tremendously underrepresented in those. There's that same potential with precision medicine. If we don't trust the healthcare system, we're going to be less likely to engage with the healthcare system, less likely to, for example, give samples of blood or other things that may help to influence and what we know through precision medicine. And so again, we have the potential, instead of mitigating disparities, to exacerbate them. And so we have to think about all of those things as we think about this move towards more precise medicine and more personalized medicine. So I just want to quickly share work. I don't have the results here for you because this is work that's still ongoing. But this is a project that started when I was at the University of Houston before I moved back to Baylor College of Medicine. And so this is work that I'm still doing with colleagues there. And this is looking at how we use data to actually predict who's at greater risk for diabetes complications. And why is that important? Why is it important for us to think about data and genetics and environment? Because we know that for every 1 point increase in diabetes complications, or in this diabetes complication severity index, we see greater rates of hospitalization, we see greater rates of death, we see greater rates of emergency room utilization. And so being able to use data, all of this data that we're amassing to predict who's at greater risk of complications, then allows us to think about the next part of my presentation, which is therapy and how we want to make therapy available to individuals. And again, you're going to hear the same thing from me. We have tremendous advances in therapy. So many of you are familiar with our GLP-1 receptor agonists. So those are your medicines like Ozempic and Zepbound, those different medications. Now, they may have one name for diabetes and one name for if they're being used for obesity, but they're the same class of medications. And so these medications have tremendous promise because they are helping us to address metabolic issues that we're seeing that are contributing to diabetes. So they allow for us not only to improve blood glucose, but they also support meaningful weight loss, and they're reducing complications, those long-term complications of diabetes like cardiovascular disease and kidney complications. And importantly, we talked a little bit about quality of life. These medications improve quality of life for individuals who have diabetes because they're often one-time-a-week injections that we're able to give to our patients that allow them to have a different type of treatment option that allows them to be more adherent to their treatment and have greater satisfaction. And so when we think about that, we see that there's tremendous promise of these medications. Similarly, our SGLT2 inhibitors, another class of medications that has become more prominent in our care of patients who have diabetes. And I really highlight this medication because we're using this medication in individuals with diabetes and also in individuals without diabetes, particularly individuals who have kidney disease, because this medication has been shown to delay the progression to end-stage kidney disease. So that is a huge complication that we see with diabetes, and being able to address that and have a way to help prevent or delay progression to that is incredibly important for our patients with diabetes. But I'm going to come back to the same thing. There are tremendous barriers in access to this medication. I'm sure you all have heard people talk about how expensive it is to get these medications. And so in the United States, one of the things that we see is that we don't have as much competition in pricing, and we don't have as many policies that help us to make medications more affordable for our patients. So we continue to see cost barriers. We see barriers with people who are living in rural areas. We see racial, ethnic, and socioeconomic disparities. And we also see issues with awareness, right? Who's asking for these medications? Who has doctors who are providing these medications? And so thinking about all of those things are important. So as we have a conference where we're talking about innovations, I think it's important for us to think about policy innovations as well, and how we use our voices in this field of healthcare to advocate for patients to be able to get the care that they need. And the last thing I'll talk about is care and health system delivery innovations. And so there are a lot of, they told me about this mouse. So there are a lot of things that we're seeing as far as healthcare delivery innovations. And I think this is really important for us to spend some time on. One of the challenges that we have, particularly for individuals who may, again, be from lower socioeconomic backgrounds, is an ability to access healthcare. So I won't go through all of these things, but I think what's important about all of these models of care is they're helping us to think about how we take care of the whole patient, and they're also moving care from the traditional clinical spaces where we are out into communities where our patients are, particularly as we think about telehealth and we think about mobile clinics. We think about our community health workers who have trust within the communities and are going out into those communities. These are all ways that we're able to meet patients where they are rather than expecting patients to come to us where we are. And this is one study that Isabel probably remembers very well, but that we worked on at the VA. And I highlight this because as we think about these models of care, it's important for us to think about integrated care models where we are providing care that is patient-centered and we're engaging patients in shared decision-making. And so we saw that when we recruited patients and we included them in an intervention that focused on collaborative goal setting, we were able to see significant improvements in hemoglobin A1C levels, which is a measure of diabetes control. So again, when we're having these conversations with patients, when we're using integrated models of care and making care more patient and community centered, we see better outcomes for our patients. And then I'll just highlight once again, I've had the great privilege of working with lots of community health workers. And so many of you all are familiar with the work that community health workers did during the COVID-19 pandemic. Well, they do work across all sorts of health conditions, and they are particularly important because they come from the communities that they serve. So again, as we think about bringing care out into communities, I wanted to particularly highlight community health workers as an innovation in care delivery. And community health workers have been used far more extensively globally than they have here, but we've certainly started to see more of that here, both nationally and locally, and integrating within healthcare systems. And again, an important innovation as we think about bringing care to our patients. So there are a lot of things for us to still do as we think about advancing innovations in diabetes care, but I hope that this quick little trip through diabetes care from the lens of a primary care physician has helped you see that there's so much promise that exists right now. The important thing is that we continue to think about how we integrate technology and therapeutics and prevention to create more equitable care for patients who have diabetes. And with that, I will stop. I've included my contact information here because I think one of the beautiful things of this type of program is that it allows us to think about where we can collaborate to continue to make positive changes for our patients. And so I've included my contact information here and would love to connect with any of you all who have an interest in diabetes care and thinking about patient and community-centered approaches.
That was a great talk, and a lot of the things that she said I'm going to echo because you're going to see some themes here. Like I said, we're going to kind of go through cardiology a little bit in the chronic management of cardiovascular disease. This is a very big topic, right? So I thought what would be more helpful to help this audience to kind of focus is to focus on one particular area of cardiovascular disease management, and that is the management of heart failure. Heart failure is a very difficult topic that we manage every day in the hospital. And it really does speak to some of the issues that Dr. Woodard was speaking about in terms of basically bringing care to where the patients are rather than relying on the old model of having them come to us. And so in order to expand care, I think that's what we really need to do. So I'm sort of giving the punchline away, sorry. Okay, so I'm a cardiologist at Ben Taub. I'm a Baylor physician, but all my time is spent at Ben Taub. I take care of patients in the inpatient setting. I see patients in the clinic. And I read a lot of imaging studies. So let's take a sort of a macro view of things, and we'll become a little bit more micro as we go along, right? So this is a slide that shows the estimated cost of cardiovascular disease, including stroke, and it's the trend of this cost from 2020 to 2050, right? So in 2020, we spent about $680 billion on cardiovascular care. This is projected to rise to over $1.8 trillion by 2050. And that is an astounding amount of money, right? And so clearly there are places that we can use our effort and our skills to try and drive these costs down. So just a big picture, heart failure. So we focus on heart failure. Heart failure, what that means is that these patients, their heart function is not normal. They often come back to the hospital with symptoms of exertional dyspnea, or shortness of breath rather, weight gain, and the reason or the etiology of their heart failure can be either related to coronary artery disease or other things that are not related to coronary artery disease. But the global burden of heart failure is on the order of 55 to 65 million people affected worldwide. The cost of this is about $280 billion, and there are sort of indirect costs. And what we'll notice here, and as well as when we focus on the United States, is that the majority of that cost comes from hospitalizations. So our efforts really need to be focused on trying to keep people out of the hospital so that they can get well, be well in the community, and treat them before they come to the hospital. That's our goal. Some of you may have heard of the initiative called Get With The Guidelines. Get With The Guidelines talks about different treatment modalities, different medications that improve mortality, and this is one of the key things about guideline-directed medical therapy for heart failure. One of the key things is to A, help them live longer, and that's through medicines, and B, keep them out of the hospital, right? Those are the two main things I tell all my heart failure patients. Those are my goals with you. In the United States, the prevalence is about on the order of 6 to 8 million people rather, and it's projected to rise to about 11.5 by 2050. The annual cost, again, It can range depending on the sources, but anywhere from 50 to almost $200 billion. So this is, I thought, was a very informative sort of picture that I found while I was doing the research for this talk. This is a diagram that shows us the United States and heart failure deaths in the urban versus the rural population, and there's clearly a huge divide. First thing I want you to notice about this map is that the majority of heart failure mortality is focused on the southeast, southern states of the United States of America, right? And we can think about why that might be the case. The top right-hand little box up there, I want you to take a look at that. For every 100 urban residents aged 35 to 64 that die of heart failure, about 167 patients, rural patients, die. So there, right away, you see the disparity in the mortality in between these two populations. And the mortality is a little bit different for the older population, but similar. For every 100 patients that urban residents that die in that age range, about 116 will die. So this tells us a lot about age and where the problems lie within our borders. Let's focus a little bit more now on Texas. In Texas, the heart failure population represents about 10% of the national number. The prevalence is about 800,000 Texans, depending on the estimates that you can read. The annual direct cost can be anywhere from 3 to 8 billion. And again, the key cost drivers are hospitalization, comorbidity burden, like diabetes management, for example, and access disparities. So these disparities often are prevalent in low-income and minority populations. In addition to that, there's a lot of significant financial toxicity related to care. These patients have a lot of medical debt. They have out-of-pocket expenses, a lot of them that cannot afford that. Our targeted strategies also, as Dr. Woodard was mentioning, include telehealth, community programs, and equitable access to care. So just a quick focus, heart failure is a major and rising health expenditure across the world. The primary driver of that cost is hospitalization. The economic burden is greatest in rural and underserved populations. As cardiologists and as physicians, our goal is to implement some of these strategies that we know through the literature, through randomized controlled trials, have proven to show mortality benefit. And this includes guideline-directed medical therapy, which includes the SGLT2 inhibitors that Dr. Woodard was mentioning, in addition to evidence-based beta blockers, mineralocorticoid receptor antagonists, and ACEs or ACE inhibitors, and neprilysin inhibitors. So, again, access versus innovation, I think, is the thing that matters the most, right? We need to get people care where they're living or where they reside, rather than try to focus on trying to get them to us. And I think that's going to help improve the quality of care and improve the efficiency of the care that we deliver. So we need to highlight our unmet need in chronic disease care in Texas and in the U.S. We need to examine technology-enabled solutions that close the access gap between rural and underserved communities. We need to translate global innovations to local Texas context through partnerships and policy alignments, and then build collaborations that provide inequity-sensitive cardiovascular needs. The rural population has a higher prevalence of hypertension, diabetes, and smoking, which are the main drivers of cardiovascular morbidity and mortality. There are fewer clinicians for these patients to see in their communities, so they have to come to us. It takes longer to travel. A lot of times they don't have vehicles. They're taking a bus to get to their cardiology appointment, which I hate to hear that. I feel so bad for these patients sometimes. There's a disproportionate number of hospitalization and readmissions among this group, and also digital inequity, rather. So patients who in this population have less access to digital innovations, phones, Wi-Fi, those kinds of things. There are other drivers of disparity, including social determinants of health and infrastructure, clinician shortages, tech or data constraints, broadband coverage, and when these patients don't have these things in place, what happens is you get this sort of feedback mechanism where lower health and digital literacy are prioritized over competing life priorities. Medication leads to access to medication and affordability challenges. And then we kind of have this sort of circular situation where patients continue to have no motion forward, no movement forward in terms of advancing their care. So how do we change this? So there are some ways, and we sort of talked about this a little bit already. Telehealth monitoring, is something that I think is going to be a lot easier to do as we move forward and these technologies become a little bit more ubiquitous. Team-based models, community health workers, which we talked about, and this is certainly something that we need to implement. Clinical decision tools, telepharmacy, and mobile health units. So these kinds of advents or these kinds of technological changes will help bring care to patients in their communities, as well as virtual and hybrid cardiac rehabilitation. These kinds of also other innovations that help bring care to where patients are rather than having them come here. At some point in a lot of their journeys, they do have to come here because this is where the advanced care happens in the medical center. But the majority of the cost happens because of unnecessary hospitalizations, that if we implement some of these changes, I think patients will have a better long-term outcome overall. Okay. I have several more slides, so I think I'm going to run out of time. So let me just go right to the end here, and I want to just sort of focus on 4 key things, right? So implementation barriers and practical solutions. So these barriers can be individual, organizational, community, or policy related. From an individual standpoint, low digital or health literacy can drive costs. How do we fix that? We can focus on programs that endorse device lending, teach back, phone first options. From an organizational perspective, there are protocols and data burden that can affect care. So this can be ameliorated by using standing orders or registries or pharmacy protocols. We have pharmacists in our clinic that we have and rely on to see patients as follow-ups in addition to and in conjunction with our appointments so that they can see some kind of a provider a little bit more frequently. In the community, transport, food, and housing insecurity can contribute to this. Community health worker navigation and mobile units linked to clinics can help ameliorate that. And finally, from a policy perspective, reimbursement and coverage gaps, especially here in Texas, and I'm sure a lot of you know about this, drive some of this inequity, and we can use value-based contracts and telehealth to reimbursement to help drive that down. I'll stop here so that we have time for our other speaker.
Thank you. Let's see. All right. Well, it's a pleasure to be here today and tell you a little bit about a new innovation that we've been working on in collaboration with multiple universities around the country, and that is Project Rogue, which is an ARPA-H-funded effort to develop a new way of delivering GLP-1 agonist therapy. So as Dr. Woodard really outlined nicely, in the United States and around the world, we're dealing with this twin healthcare epidemic of obesity and type 1 diabetes, which really accounts for over $1 trillion in healthcare expenses in the U.S. annually. And so this is a very challenging problem, both from an economic standpoint, as well as Dr. Woodard highlighted, some of the challenges from the patients and how it really impacts people of different socioeconomic statuses differently. The good news is there's a marketplace now where multiple GLP-1 agonists are FDA approved. These biologics are very effective in managing blood glucose as well as weight loss. But one of the things that this highlights is, unlike other innovations, other marketplaces where as competition grows, pricing goes down, in biologic drugs, this rarely happens. And in fact, we see an increase in pricing as more and more competition enters the marketplace. And so this is a market that really needs to be disrupted. Some of the costs come from the enormous cost of manufacturing. We all know the pharmaceutical industry has a lot of greed. Just to give them a little bit of credit, it's actually quite expensive to make these medications. And we do need new models of both manufacturing as well as delivering them to the patients. So on average, these medications cost about $900 to $1,200 for a 30-day supply. And unfortunately, insurance doesn't really cover most of it. So while they're very beneficial to patients, oftentimes patients who absolutely need it are having to work, double shifts in order to be able to afford their copays. And the sales are growing, pretty exponentially. If you compare 2018 to 2023, now there's a marketplace of $71 billion annual sales of GLP-1 agonists. but it is really not benefiting everyone equivalently, and the people that really need it can't really afford it. The other challenge with these medications is the compliance. They do have to be injected, and we know from the experience of going from oral medications, which were once daily, to once weekly injections, actually the compliance improved quite drastically, but still the burden of having to, keep these drugs on ice, the injectables, you have to keep them in a fridge when you're traveling. They really are a burden on patients, and so many patients don't take the medication they need. And as we think about beyond what's happening in type 2 diabetes and obesity, there's an ever-growing number of indications where it's now becoming clear that this type of medication is going to be broadly used for many, many diseases. And unless there's a disruptive approach, like this is going to create a huge healthcare economic crisis for us in the US. We asked a question, and we're really appreciative of our page's support of this, was what if your body could make its own GLP-1 agonists? That would really simplify manufacturing, delivery, and compliance. And so we imagine a future whereby rather than producing the biologics in cells and giant steel bioreactors that ultimately need to be purified, stabilized, and put into injectable vials, we simply create the engineered cells. We combine them with biomaterials that protect these cells from the host immune system. And our vision is to build miniaturized little bioreactors that could be inserted subcutaneously, and they could be controlled remotely to enable production of the biologic in the patient on an as-needed basis. And we think that this provides really unique advantages in the ability to address the compliance issues, but also because we're using living cells, we can hack into cells' unique ability to sense their environment and produce systems that are not just always on, but on conditionally. And this is actually something that we're advancing towards clinical testing. We have versions of this technology that's in the clinic already for cancer applications, and we hope that the GLP-1 agonist will be in the clinic in 3 years. In fact, we're already funded by our page to do that. But we're now in a place where we can keep these cells alive in animals, and in some cases in humans, for the duration that we want. And so once administration, for 1 year of activity. And this platform now allows us to actually build in the control to make this quite drastically different than what patients have to deal with today. And so we imagine a future whereby the physician and patient are able to communicate with these living devices and are able to have the biologic production. And the way that this works is, let me just see. Okay. So we're leveraging advances in synthetic biology to create cells that produce the GLP-1 agonist with electrical actuation. The same cells actually produce a reporter, which allows us to regulate dosing. And the devices have built-in glucose monitors, just like the technology that exists, and allows us to actually be able to have these living therapies produce the biologic on a dosing regimen that makes the most sense for the patient. The way that this gets implanted is it's a trocar administration that goes underneath the skin. So it's 3 millimeters wide, and the length is less than a centimeter. It's modeled after many of the contraceptive devices that are implanted today. And it's that size that allows us to produce the dosing that's needed for the patients. And so on board, there's electronics that support the cell. There's oxygen generation that happens that keeps these cells alive. We use electrolysis, which is an old chemical engineering reaction whereby you can split water, generating hydrogen and oxygen. And that's the oxygen that's needed for the bioreactor. The device has Bluetooth that communicates with an app that allows us to program it to produce the biologic when we need it. And it collects all the data from the glucose sensors and how much drug is produced and communicates back with the app. So this is kind of what our initial prototype of what this looks like. And it can be administered and retrieved. And this is how it works. With pulses of electricity, we can actually control the production of drugs like duoglutide, exenatide, and we can create dosing regimens based on how much we're producing. We're working with experts like Oleg Agoshin here, who's helping us with machine learning computational models that allows us to predict, if we're producing X amount, what does that correlate with in terms of the levels in the blood, so that the patients can maintain a steady blood level that's needed for the therapy. And this all communicates with an app with the patient in the loop. So as we're doing the trial, the patient can actually report their symptoms, be able to control where they have the production. We know that GLP-1 agonists are very effective, but the current paradigm of how it's dosed today, where you get 1 week's supply injected subcutaneously, and you have little bits of it dissolving into the bloodstream. Well, most patients report the first 3 days they have quite a lot of nausea and discomfort, and that's because they're being overdosed initially. And then at the tail end, it stops working, so you have to get another re-injection. But what about a future whereby you could just program this device to produce the GLP-1 agonist between 10 a.m. and 2 p.m., and then again during dinner time? I mean, you don't really need the GLP-1 therapy at night when you're sleeping. So this could really transform how it is. And we also think about a future whereby it's no longer trying to overdose patients to lose a lot of weight, but to have this type of technology available for what would be truly healthcare, and that's resetting the metabolism periodically without having to overdose. And we think that these kind of technologies are going to be transformative. And what is going on here? Okay. And they are actually working. We have prototypes that are in animals now where we can produce the GLP-1 agonist and affect weight loss, blood glucose levels. We're screening different GLP-1 agonists and combinations to be able to get this to work in patients, working with clinicians at the Mayo to design the trial. And this project is scheduled to advance to human testing in 3 years from now, actually. So we have quite a lot of work to do, but we're excited to build this. And again, we imagine a future whereby these kind of technologies could replace most biologics. We imagine a future whereby rather than getting a physical prescription, you get a digital prescription that the doctor calls in and communicates with an app that then triggers the production of different biologics based on what is needed. And these devices can be used to produce any kind of biologics. In fact, we have an effort in my lab. There's currently 330 FDA-approved biologics, and we're working through creating cell-generated version of a whole bunch of these. These are medications that, you see a lot of commercials for on TV, drugs like Humira, Skyrizi, Dupixent. They're very expensive to manufacture. I mean, they cost about $2,000 a year to the manufacturer for 1 year's supply. Of course, they price it at like $25,000 or $50,000 a year. But what's great about this technology is we can produce it for $100 for one implant that lasts perhaps for 1 year. And that's the impact we can have as innovators, is how to create low-cost solutions. And of course, the marketplace will figure out pricing. But I think, this is where we hope to be advancing. And I wanted to thank my team at Rice, who are really helping with this, but also our collaborators. Again, this is a big effort with Sai Cohen-Carney at Carnegie Mellon University. We have collaborators at Northwestern, Georgia Tech, the Mayo Clinic, and Joslin Diabetes Center. And of course, our funding sources. So with that, thank you.
So as Dr. Woodard mentioned, there are a lot of undergrad, high school, medical school, doctoral level students here in the audience. And thinking back on your career trajectory and the current state of funding and research speed and society's views on health and pharmacologics and interventions, what advice would you give students or trainees here in the audience on advancing their careers if they'd like to get into your type of work?
I had a very circuitous route to where I am right now. I actually went through graduate school before I went to medical school, and I was the second oldest person in my medical school class. But in spite of that, I think we have an opportunity to really make a big difference. And one of the things that I just recently gave a talk to the medical students. One of the things I think that's really difficult as scientists and physicians is trying to adhere to the truth. And right now, there seems to be an assault on truth. And so it's important that we maintain our scientific integrity and really try to be voices for the truth out there and make sure that the right information is being conveyed to people who may not understand it, and make it accessible to people who may not understand it.
So I would echo that. I think it's so important as we see a lot of people questioning science. What's been a big shift for me is I think patients always really, I felt like, trusted the information that they were getting from their physicians. Now, we know that's different by communities, of course, sometimes, but it's been really interesting to sort of watch the growth of sort of anti-science and misinformation. And so I agree with being a voice for the truth. The other thing that I would say is that we're seeing a lot more technology influencing how we provide care. And I think, one, as clinicians, we have to be open to that and accepting of that, because it's something that our patients are going to expect us to do, and to be able to have conversations around them and around the information that they're getting from technology, but help to guide them to get accurate information, because there's a lot of bad information out there. But also, as we see more and more technology, just to always remember that the practice of medicine really is about human connection and empathy and compassion. And so thinking about how we mix technology while still maintaining that humanism and compassion in care of our patients, I think is incredibly important. So I would really say that to young people who are thinking about going into medical careers.
Yeah, I'll just echo that. It is a really exciting time because we have this confluence of, advances in our understanding of biology, as well as technological advances like wearables, implantables, and AI. And I think that confluence is really creating unique opportunities to provide patients with a lot more information about their health, which allows them to make better decisions. I mean, like the iWatches, the Oura Rings. I mean, it's really amazing how that is really guiding people. I mean, there's like apps out there where you can take a picture of the food that you're about to eat, and it tells you, is this good or bad? And I think like it's more and more information, but of course, part of that comes with a bit of information overload. And I think that's the important role of the clinicians to help guide patients as to what's really important. And we don't want to create a hyper-stressed society, which doesn't really know what to do and is just overwhelmed with lots and lots of information.
So one of the things I really loved about this panel is we've got this amazing mix of healthcare providers on the front lines and the most cutting edge of technology. And I'm wondering if you can think about, is there something in the middle? I'm so impressed that 3 years is the timeline to testing in humans, but 3 years is a long time still. And are there opportunities for innovations that have a shorter time frame that could be helpful in terms of the clinical challenges that you're facing that can help bridge the gap to getting to some of the cutting edge innovations that Omid was talking about?
Well, I will start with that. So I think that's a really great question. And I would say for me, the first piece is going back to what you said, right, is the amazing things that we have available, helping them to be accessible to all. Because right now there are a lot of things that exist that can help with treating our patients and improving our patients' quality of life, that if we just made those things accessible to the broader population, we would see tremendous improvements. And I mean, that goes from not only medications, but wearables, thinking about technology access, broadband. If we just did that one step, I think that's a huge a way to bridge the gap between where we are now and what we will potentially see in 3 years. And you're right. I mean, we know that it takes a long time to go from bench to bedside. And so I'm so impressed with the 3 years. I think that's amazing. Although I know there's a lot of work that's gone into that before. But I would say really being able to take all of the transformative things that we have now and make them broadly available would make a huge difference. And I think that requires us to be advocates and to really think about policy innovations that help us to make sure that these therapies are available more equitably.
Yeah, I mean, I think with regard to cardiovascular care, we have medicines that work. I think what doesn't work is that information doesn't, once the patient leaves your office, it's hard to know what they're doing, right? A lot of these patients, in one of the key features of heart failure management, for example, is just weighing yourself every day and writing that number down. So a lot of patients don't even have scales. So these are really simple things that we could implement that would have a big change or a big effect on patients' overall outcome. And because they don't have access to these things, they don't have the education, they end up coming back to the hospital because that's their last, that's the last place they go to. They have no other resource.
Yeah, I mean, I think we really shouldn't wait until 3 years or even longer for these technologies to get there, because elements of it are practical today, and some of the tools exist. Like, I mean, many patients actually, so glucose monitors exist now, and they are covered by insurance, but a lot of patients still don't use it. So how do we improve access to that? I think the wearables is really an exciting area because you can quickly innovate and bring those type of solutions to market. Like the new Apple Watch tracks hypertension, which is really exciting, right? Because that's a thing that most people are really unaware of. And if you get ahead of it and you make lifestyle changes, it can really result in reduced cardiovascular events and other complications. So.
A lot. Okay, so a lot of the panelists today talk about how technology is less accessible to people of certain socioeconomic grades, I guess. And how do you think that impacts Dr. Dese? Is that how you say your name? How do you think that impacts your work, especially in terms of patients trusting the technology?
Well, I think that's a really important question. And I think one of the things that as we're these ARPA-H projects are great because they always have to have a market research and an ethical and societal impact evaluation. And at the end of the day, like, I think implants can be transformative, but for people to trust them, they have to be in control of them. And so devices like this, and that's why when we were thinking about the app, we want to be mindful of, well, the patient should be the decision maker. And in fact, all the glucose monitors and insulin infusion pumps today, they still require the patient in the loop, even though the technology exists to allow the system to just do the administration itself. There are thresholds that the patient has to set. And I think it's really important because you always want the patient, it's their body, it's their choice, they need to be in control. And these autonomous systems, I think, are not going to be accepted unless they have a choice in the matter.
So I just want to thank you for that really, really important question, and just add that, my work in community engagement reminds us of the importance of engaging our communities very early on. And I will continue to go back to, because I think it is such a recent example, but as we saw, for example, new vaccines with COVID-19, you saw a lot of people who did not want to take those vaccines because they did not have trust of our healthcare system. And where you found the most effective interventions, it was from people like community health workers or from institutions who had long-standing relationships in communities where they were able to come in and have that trust. We saw a lot of work that happened with trusted messengers. So we had a lot of people who were in our churches and our barbershops and these sorts of places as ways that we could reach individuals who may not trust the healthcare system, but they trust these trusted messengers. So I think the importance of, you talked about market research. So that's really about having our patients and our communities involved at the very beginning of the work that we're doing as we're developing it, but then also continuing to build those relationships and work with communities. I think so much of what we have to do to build trust is really relational.
First comment is that the presentations from each of you, I thought, were well organized, well thought out, and well presented. So congratulations to the panel. I have a separate question for each person, and I'll go in the order of the presentation. So for Dr. Woodard, regarding the use of the continuous glucose monitors, which is a real advance, but it's been a long time coming. These technologies have been in development for over a decade, maybe even more. Were slow to be approved by the FDA. But even now, there is some inaccuracy in them. And just from your perspective as one who uses this and sees patients who use these, talk about the level of utility despite the fact that they're not perfect.
And no, that's a really great question. So I don't think that any technology is perfect. I don't think that any clinician is perfect, right? I think that medicine is in many ways imperfect because there's the human element, there's the technology element. But what I will say about continuous glucose monitors, if you think about the way we checked blood sugars previously, right, where we were checking our blood sugars, some patients may do it one time a day, some may do it 3 to 4 times a day. There's this huge period in between where we have no information, no idea what's happening with your blood sugars, right? So that information, while accurate at that moment, did not provide a comprehensive picture of what was going on with our patients. And that's why you would have times where your patients had very low blood sugars or potentially very high blood sugars. And so the benefit of continuous glucose monitoring, which does have high accuracy rates, not perfect, but the benefit of that is that you have ongoing real-time measurement that allows then for, particularly if connected to an insulin pump or, that sort of infusion, allows those real-time adjustments. And as we talked about, having information that's conveyed to the patient allows the patient to see that and provides more information for them as they think about how they can modify what they're doing, and more information for them to share with their clinicians. So again, it provides so much more information than we did have before. It's incredibly beneficial.
So I really wanted the students to hear that. It was a great response, that you can develop something that has utility even though it doesn't have perfection. So my second question is for Dr. Bulathings Hala. Hopefully I pronounced that correctly. So as a cardiologist, you no doubt know Nanette Winger. Perhaps? I hope so. No, you don't.
I apologize. I don't know that name.
Oh, okay. So Nanette Winger is a cardiologist who's now about 94 years old. She's one of the authors of the standard textbook, The Heart. Willis Hurst, The Heart. So she's at Emory. And for the students, she's quite an inspirational story. It is a little bit of a divergence because she was in the first class at Harvard that admitted women into medical school as an explicit experiment to learn whether or not women could learn medicine. That was a hypothesis. So they admitted 6 classes of women under this hypothesis to answer the question whether or not women can learn medicine. She was one of them, and she's still alive and well now. So I saw her at the American Heart meeting last year, and we talked about technologies. I'm from A&M, School of Engineering Medicine. And she said, these wearables are fantastic. So, some comment to Omed's last statement. And what we see in patients in renal failure who really get into trouble are these electrolyte shifts. And if we had wearables that could detect electrolyte shifts, they could really be helpful to us and perhaps mitigate some of the decrease in longevity that patients have who are chronically on dialysis. So this may be a little bit too much of a question, but I'm just wondering about your experience in your practice in patients on dialysis who have failure, who get into renal failure, go on dialysis, and your perspective on whether or not wearable technology could be useful in managing these patients.
Thank you for that question. Yes. So with regard to renal failure, it's one of the biggest issues that we face in hospitalized patients. Going back to my talk about heart failure, when we manage heart failure patients, the key to most of these management modalities is to get them to pee. When you have a patient with ESRD, the only way that they're going to get that fluid out is to be dialyzed. If we can improve our ability to manage those patients in the outpatient world through wearables, either by managing their electrolytes, making sure that they are able to understand, their volume status, I think that would be powerful, very powerful, because it would improve adherence. It would prevent rehospitalizations. It would prevent these patients who are on dialysis from having to stay in the hospital for multiple days at a time, getting extra dialysis sessions to get them back to euvolemia and back to a place where they don't have symptoms. So I think it would be a powerful advent.
So another call for our students.
Wonderful. I know you said you had a third question, but I would like to give the opportunity to somebody else. But thank you for those wonderful questions.
I'll ask Omid when we break.
Wonderful. Sure. Thank you. I know that there were some students who were at the microphone. The speakers' emails are in the program, so I don't want to cut you off of your questions, but please feel free to reach out to ask any questions that you have, and they may be around for a couple minutes afterwards. You were first at the mic. If you have I think we have 1 minute left, one final question.
Yeah, thanks. A technical question for Dr. Omid. Can you say a little bit about the accuracy and precision of the dosing done in your device? Because in traditional pharmaceutical manufacturing, there are tons of quality controls where things are checked many times to make sure that the dosing is exactly right. So curious what that looks like in your device.
Yeah, that's a great question. So we recognize that with living cells, there may be some variability, but the way we engineered the cells is they actually co-produce a reporter molecule that is optically active and stays inside the cell. So we use that to calibrate how much drug is getting out. And we're doing a lot of calibrations right now in the animal studies to kind of calculate, this signal, what does that mean to? And then we also have the blood glucose monitor. So hopefully we'll be able to dose to a pharmacodynamic level as opposed to just PK levels, which is what, is happening today.
Yeah, very cool. Thank you.